gives us an opportunity to interact with you people. And today I'm going to share with you a problem which is common and which has got serious consequences, and which, in my opinion, we deal very casually with predictably bad results. So, corn bile duct stones are estimated to be present in 10 to 20% of individuals with symptomatic gallstones. And symptomatic gallstone is a common presentation in the surgical OPD. There are serious consequences of missed or retained corn bile duct stones. In spite that there are a number of valid options to diagnose and treat individuals with suspected CBD stones. There are a number of questions which come to my mind, and these are: when should investigation and treatment for corn bile duct stones be considered? In which case? What is the best way of identifying patients who have corn bile duct stones? And when undertaking endoscopic retrograde cholangiopancreatography for CBD stones, what can be done to improve the success rate, because ERCP is associated with a certain failure rate and is associated with complications? So how to minimize those risks? What is the role of surgery in managing corn bile duct stones in this day and age? In patients with corn bile duct stones that are difficult to treat, what are the management options? And how should corn bile duct stones be managed in the most commonly encountered clinical settings? Now, the probability of CBD stones can be established on history, alteration and liver function test, and transabdominal ultrasound. And we can divide the probability into high likelihood, intermediate likelihood, and low likelihood. In high likelihood, if there is a calculus visible on CBD or ultrasound, if there are features of cholangitis, or if patient presents with a combination of corn bile duct dilatation on imaging and jaundice. Then there is an intermediate risk group which has pain with abnormal liver function test in the absence of duct dilatation, or vice versa. There is no duct dilatation and LFTs are deranged, or duct is dilated but LFT are intact. Then there is low likelihood of corn bile duct stone when we have the normal liver function test, when ultrasound finding is normal, and there is no history of cholangitis or gallstone pancreatitis. Further investigation with low or intermediate likelihood of corn bile duct stone is recommended prior to undertaking endoscopic or surgical bile duct clearance. In high likelihood cases, we straight away go to endoscopic or surgical clearance of corn bile duct. Transabdominal ultrasound and liver function tests are done almost routinely in all suspected cases, and normal results, however, do not exclude presence of corn bile duct stone. For patients with intermediate likelihood, MRCP and endoscopic ultrasound is recommended as next step, unless the patient is proceeding directly to cholecystectomy, where there will be availability of intraoperative cholangiogram or laparoscopic ultrasound. CT has limited role, and it is done only when we suspect CBD obstruction and malignancy coexisting. Now, ERCP is the primary means of CBD duct stone clearance. However, there is potential for serious adverse event. To reduce the risk of post-ERCP pancreatitis, which is a very known entity, it is recommended that NSAIDs should be administered at the time of ERCP to all patients who do not have any contraindication to NSAIDs. For selected patients, tolerability and likelihood of therapeutic success is higher if ERCP is performed with propofol sedation or general anesthesia. This is very important. Person who is doing ERCP should have recourse to general anesthesia if patient does not tolerate it. Otherwise, the failure rate is very high. When there is failed endoscopic cannulation of corn bile duct, percutaneous or endoscopic ultrasound guided procedures can facilitate subsequent ERCP. Percutaneous image guided anti-grade biliary catheterization via the intrahepatic ducts or corn bile or the gallbladder through which a guide wire is infused into the duodenum to enable retrograde cannulation. Endoscopic ultrasound guided biliary drainage has been described as an alternate to percutaneous intervention. Some of these facilities are available in the Lahore General Hospital or other gastroenterologist unit which are highly equipped. The percutaneous intervention involves accessing the intrahepatic ducts, which usually involves puncture of the left lobe of liver via the stomach. Now, surgical management of CVD stones, intraoperative cholangiography or laparoscopic ultrasound is suggested for those patients with intermediate to high probability of CVD stones. Now, laparoscopic ultrasound is available in very few centers. One of these is Jinnah Hospital, Lahore. I don't know of other centers. But intraoperative cholangiography is a low-hanging fruit. And all the general surgical operation theaters which have image intensifier, they should be doing at least selective intraoperative cholangiography. Intraoperative cholangiography or laparoscopic ultrasound can be used to detect corn bile duct stones in patients suitable for surgical exploration or post-operative ERCP. In patients undergoing laparoscopic cholecystectomy, laparoscopic bile duct exploration is an appropriate option, and we must train next generation of surgeons in laparoscopic corn bile duct exploration. It is associated with shorter hospital stay, and the outcome is otherwise comparable with ERCP. Now, what to do with ductal stones? You can do ERCP, but you cannot remove the stones. In these cases, percutaneous or ultrasound-guided procedures can facilitate subsequent ERCP. Combined ERCP exploration and CVD exploration and ERCP are highly successful in removing these difficult ductal stones. Now we need to have an algorithm for CVD duct stone management. And laser pointer. Okay, if you suspect corn bile duct stones, the first investigation is ultrasound, abdominal ultrasound and liver function test. And it then divides these patients into three groups. Low likelihood with normal ultrasound and LFT. However, these can have still stones in corn bile duct. Intermediate group which have normal LFTs and dilated duct, or abnormal LFT with normal calibrability system. And in high likelihood of corn bile duct stones, there are stones on ultrasound, or there are features of cholangitis, or other features which make it sure that there are stones. Most of the patients follow in this or in intermediate group, and in intermediate group, we have to resort to MRCP, which is quite freely available, or EUS, which is also available in centers of excellence. And at the end, we know that there are stones or no stones. Those patients in which there are normal LFT and ultrasound, and patients still have symptoms, consider alternate diagnosis. Those patients who have high likelihood of CVD stones need these corn bile duct to be cleared, and CT is done only when there is a risk of malignancy. Those patients who are found to have CVD stones need to proceed to either surgical extraction or ERCP. And if there is failure of these, then consider percutaneous radiological techniques in such cases. So you need to have your own algorithm. Now we need to make sure that it's not only the surgeon who decides what to do. It's a multidisciplinary management, and we need to know the strengths of radiologists and the strengths of gastroenterologists. Now, as surgeons, we should ensure that intraoperative cholangiogram facilities are available. Some people do it in all cases, others do it in selective cases, some do it in high-risk cases, and I would like to know what is your choice. Is any one of you doing intraoperative cholangiogram? Very good. And I do it selectively. Okay, then perioperative ERCP. Do you do it before lap chole or after lap chole? Most people do it ERCP first and lap chole later on. But I do it the other way. I do lap chole first and then I do ERCP unless patient is jaundice. Mere presence of stone does not mean that you have to clear the corn bile duct first, because many times the patient is lost to follow-up. He gets corn bile duct cleared, he gets relief of symptoms, and comes 3 years later with a stent with a stone occupying whole of the CVD. So I very much, with great difficulty, I remove such large stones. So what I do is, in all cases, I explain them that they will need clearance of corn bile duct with ERCP. I take them to operating theatre, do the lap chole. I suture ligate the cystic duct to ensure that it doesn't blow out. And then I do chemical sphincterotomy, which is giving no spark in maximum dose. And this keeps the sphincter of OD relaxed, and it prevents post-operative pain. And then I have already scheduled the patient for ERCP and send them for ERCP. I find following this pathway, my patients don't develop pancreatitis or cholangitis, and I don't have to delay the lap chole. So patients are not lost to follow-up, and that I don't get the blame for pancreatitis when it is because of ERCP. So this is my choice. So just to conclude, we need to have a high index of suspicion for CVD stones. Corn bile duct stone management is a multidisciplinary team work. It involves at least surgeon, gastroenterologist, and radiologist. And gastroenterologists are doing wonderful jobs. They are doing endoscopic ultrasound. They are doing ERCP after bariatric surgery or after Billroth surgery. My patients who have been dealt this way. There is need to develop a local algorithm depending upon the facilities that you have, and I impress on all the surgeons to develop the capacity for intraoperative cholangiogram, intraoperative ultrasound, and laparoscopic cholecystectomy. Laparoscopic chole is this technique followed by ERCP when both these are needed. So this is how I manage these patients. So thank you very much.